The mission is to bring together the community and providers in order to improve cancer care from prevention through survivorship by empowering the community to identify their needs and assist in creating solutions. We focus on healthcare disparities and access to care issues to ensure that all communities and populations equitably share resources. This live event has been approved for the 1.0 AMA PRA Category 1 credit by University of Rochester School of Medicine and Dentistry, accredited by the Accreditation Council for Continuing Medical Education. Throughout our presentation, please feel free to enter any questions into the Q&A box located at the bottom of your screen. I would now like to introduce to you Dr. Lee Wilkie. Dr. Lee G. Wilkie, the Hendricks Endowed Chair in Breast Cancer Research, is a tenured professor of surgery, the Associate Director for Clinical Research for the University of Wisconsin Carbone Cancer Center, as well as the Director of the University of Wisconsin's Health Breast Center in Madison, Wisconsin. She received her undergraduate and medical degrees from Duke University and completed a surgical residency at the University of Michigan. In 2000, Dr. Wilkie returned to Duke and during her tenure assisted in the development of the breast cancer survivor and high-risk clinics, as well as worked as medical director for the American College of Surgeons Oncology Group. In 2010, Dr. Wilkie moved to Madison, Wisconsin as the director of the University of Wisconsin Health Breast Center and implemented a strategic plan to rapidly expand the research and clinical programs with resultant 10 to 20% growth annually. Dr. Wilkie is currently the Vice Chair of Research for the University of Wisconsin's Department of Surgery, Chair of the Research Committee for the American Society of Breast Surgeons, as well as member of the Board of Directors for the Alliance for Clinical Trials. She is the principal investigator for the University of Wisconsin National Clinical Trial Network, lead academic participating sites grant, and works locally and nationally to provide innovative device and pharmaceutical clinical trials for cancer patients. In addition to all of this and working for breast cancer patients, Dr. Wilkie enjoys traveling with her husband and 2 adult sons. So at this time, I would like to welcome Dr. Wilkie to our event, and it's all yours.
Thanks, Karen, and thanks, Christina and Pamela, for the invitation. Hopefully everyone can hear me okay. I'm going to now share my screen and really appreciate that fabulous introduction. Some of the things I forget I do. And so hopefully everyone can see my slides now as well as myself and hear me. So I think we all have kind of gotten a little bit tired of hearing about this incredible year we've lived in, but it is now a year. And one of the things I wanted to talk to you about today is understanding kind of the pandemic's impact on breast disease, but primarily mammographic screening and breast cancer. And I thank the group organizers and this community conversation platform, because I think it's a wonderful way to bring up the issues that you're seeing in your community, as well as understand what is happening nationwide. So, as we all know, the coronavirus is an invisible foe, and I would actually argue that breast cancer is as well. There have been 125 million new cases of COVID-19 worldwide based on the World Health Organization dashboard. At the same time, there has been 2.2 million new cases of breast cancer based on, again, national worldwide statistics. My nursing staff, though they are not socially distanced in this picture, and I just realized that, have been a fabulous team, as I'm sure every breast center has been over the last year, to help us manage our patients who present with new breast problems, mammographic abnormalities, and/or a diagnosed cancer. And we consider ourselves, even though we're not taking care of directly the COVID positive patients, to really be on the front line of trying to understand how best to take care of our patient population during this time. So I have to give a shout out to the person who probably helped invite me to give this talk, is Dr. Ruth O'Regan. She was a fabulous partner in crime in our breast center over the last 5 years, as she was the director of hematology and oncology at the University of Wisconsin. For those of you who don't know, Ruth is an unbelievable expert in novel therapies for breast cancer. And this actually started when she was at Northwestern working in Craig Jordan's lab. And she has been a leader of numerous clinical trials looking at all types of breast cancer, but specifically triple negative breast cancer, and especially in those of African American descent. She is, however, an amazing and true patient advocate and supports patients from all backgrounds. And we were at extreme loss to lose her to the University of Rochester, but you all should feel very blessed to have such a fabulous leader. So I want to highlight something that doesn't show up in the New England Journal of Medicine case reports very often, is a case about breast cancer. And believe it or not, case 22 of 2020 was a 62-year-old woman with early breast cancer during the COVID pandemic. And clearly, this has been an impactful process to figure out how best to take care of our patients with such regional and national variation in what we could do. Where mammographic screening was shut down, where operating rooms couldn't function at full capacity or any capacity, and patients couldn't come into clinic, and telehealth rapidly expanded. But for patients with a palpable breast mass, I'm going to say that telehealth wasn't really easy to do. So I want to highlight this case report because what it brought forth was kind of an algorithmic approach to taking care of our patients. It really involved multidisciplinary team discussions around, does the patient need surgery? And if they do, could we justify it in the setting of very limited operative resources? Or did we have medical therapy options that were safe in the setting of an unknown impact of chemotherapy and immunosuppression on COVID-19 as an infection, as a viral infection, and those two put together? So what I'm going to try and highlight for you today is a few of the things we've learned over the last year as a result of what happened fairly acutely and abruptly in March. So groups of individuals around the country got together right as the pandemic hit, and rather impressively so. Groups from the American Society of Breast Surgeons, the National Accreditation Program for Breast Centers, Commission on Cancer, the American College of Radiology, and NCCN, the National Comprehensive Cancer Network. And individuals from each of these societies got together and came up with a prioritization of care based on regional impact, public health resources, and cancer subtype for how to treat breast patients. And then this was summarized several months later through the Annals of Surgical Oncology editors, where they really came together and said, in treating patients with breast cancer, you need both the multidisciplinary team, an understanding of your public health system, as well as how the treatment options would affect care and cancer care priorities. Could we triage within our different types of cancers? So this led to really thinking about our specific breast cancer patients in a scenario manner. So for patients that had estrogen positive cancers, the biggest and most dramatic change that has happened over the last year is the increased use of what's called neoadjuvant endocrine therapy. So for patients that have breast cancer and it's estrogen positive, we have the option of placing them on a relatively non-toxic therapy, i.e. something that might not be influenced by a COVID-19 infection, that being kind of an anti-estrogen approach, the drugs people know about the best, are tamoxifen or anastrozole. And really using that as a bridge while we figured out what we could and couldn't do during the pandemic. And however, patients that were estrogen negative, we prioritized for getting neoadjuvant chemotherapy in as safe a possible manner, and really kind of delayed treating any early stage 0 atypical or benign lesions. And a group at Mass General came up with a re-entry tool for how to prioritize patients that had been delayed for getting back into the operating room or getting back into either radiation or chemotherapy treatment. So let's step back now and see what happened over the last year in terms of mammographic screening. And where did we start? And the best place to kind of start is through the National Health Interview Survey, which provides us data from 2018. And our goals in terms of mammographic screening are around 80% of a population. That's kind of the national goal. And so in 2018, based on a National Health Interview Survey, white and Black individuals between the ages of 50 and 74 received mammographic screening around 77 to 78% of the time. Hispanic populations a little bit lower in the 70% range. But what's most notable is when you triage by federal poverty level or those that are uninsured, we see dramatic decreases in the amount of mammographic screening that happens in these patient populations. So what happened during COVID? How did COVID impact these numbers? And what are we going to hopefully see in the rebound as we start to get increased rates of vaccines, reduced rates of COVID infections that impact hospitalizations, and our ability to care for patients in both the inpatient and outpatient settings? So an interesting study was just published by the Breast Cancer Surveillance Consortium. And for those of you who don't know, this is a group of both more academic and private setting and or public setting groups that provide all of their mammographic screening data to a central repository. And they come from these groups around the country: North Carolina, Chicago Metro, Colorado, New Mexico, San Francisco, and the Kaiser Permanente group in Washington. It really is a diverse group of patients and data, because the Metro Chicago area gets us that urban disparate group. Colorado and New Mexico can get us more of the rural area, as well as the Hispanic population. And then the academic settings, usually the academic kind of exposure comes from the San Francisco, Carolina, and sometimes the Kaiser group. But what you can see in monthly mammographic volume from January to July of 2020, where we were in a steady state of percent of mammographic volume, what volume did we go from in January and February of 2020 to April and May of 2020? And what we see was almost to zero. And this was at all of the groups around the country. Now, it has rebounded, but technically it should rebound above above 100%, because we're now in a deficit. We now have patients who've gone without mammographic screening. And though we've come back to 100%, we still need to make up ground for about the 3-month time period of near zero mammographic screening. Now, this is just one representative publication, but I would say that when you look across smaller groups and larger groups, you see actually the same story, that everybody went to about zero, and most of them have rebounded to within the 80 to 90 to 100% range. And the BCSC actually looked at subpopulations and what happened to them. And interestingly enough, when you look across ethnically diverse populations, what you see is that the white and Black populations actually rebounded very similarly, but the Asian and Hispanic populations haven't reached back to that near 100% mammographic screening rate. And this was an interesting study because, again, this includes a moderate amount of regional diversity and ethnically diverse populations. And really, it was the Asian and Hispanic populations that haven't yet returned to kind of their standard screening regimens. And interestingly enough, this is probably related to age as well as socioeconomic status and a few other factors, but not totally understood yet. And so this is just early data and then trying to dive in and understand where some of the disparities are happening and why. So another kind of interesting publication that was published in Cancer looked at specifically North Carolina, 7 academic and community centers. And this was, again, the population impact of COVID-19 on breast cancer screening, diagnostic, and now we've added in biopsies. So the top line shows, again, that V-shaped curve of a dip down to near zero, and then we're starting to rebound back up in screening. Diagnostic was a little bit delayed because the diagnostic imaging follows mammographic. And then biopsies, again, have dipped down low and then are now starting to rebound. Utilization differed by breast cancer risk and insurance status in this North Carolina population, but didn't by age or race or ethnicity. And so I think that's an important and consistent theme across these studies, is that we are seeing populations rebound despite their ethnically diverse backgrounds. However, insurance status and socioeconomic status can make an impact. So this, I just picked 2 primary publications, but what you'll see is there's multiple coming out now. Disruptions in preventative care. One of these is from the group out of Pennsylvania with some discussion and information from some northern New York areas. Early stage radiology volume effects across the United States. So I think it was a very consistent pattern that happened across the United States, where we saw a V-shaped curve down to near zero for mammographic screening, and now are starting to see a rebound, but nobody's above that 100% line yet. So let's shift gears a little bit and talk about what's been happening now that we're getting widespread vaccinations, which we're all thrilled about, and how that's impacting this screening mammographic population. So this is just a very small smattering of media outputs regarding mammograms, lymph nodes, and the COVID vaccines. So I'll give you a really good example. I had a patient who's a nurse that works in our health system who happens to be one of our breast cancer patients. She's a few years out, and she was one of the lucky few to get vaccinated early on in December. And immediately, I don't know, 3 or 4 days later, she's in clinic saying, my lymph nodes are enlarged. My lymph nodes are enlarged on my cancer side. Why? Why? And she's very in tune with her body. And at that time, we weren't 100% certain. And we ultrasounded her and said, well, on ultrasound, these look like inflammation and don't look like they're filled with cancer. So, you know, a group of ultrasonographers, people who use ultrasound to look at the body, can really sometimes tell the difference between inflammation and cancer. Not always, but sometimes. And so we were reassured that this appeared to be related to an inflammatory event, and then kind of hit us that it was probably the COVID vaccine. And so this is now happening, you know, widespread. And what has happened is we've learned that the COVID vaccine probably causes, and a select group of people, we're not certain exactly how much, it's estimated in the 20% range, that we're seeing these enlarged lymph nodes that are temporary, and they do go back to normal. And so the American College of Radiology has put forth kind of a algorithmic approach to how to manage this. So people are showing up in the ER for their appendix, and they happen to get a CAT scan, and you may see enlarged lymph nodes under their armpit, or they're getting a PET scan for evaluation of their melanoma. And so we have to have an approach to managing those enlarged lymph nodes based on when that COVID vaccine was given, and what we can anticipate, and whether we should worry about those lymph nodes or not. And so I think one of the most important take-home points is that the patients communicate with the radiologists and technicians, letting them know when they had their vaccine, in which arm, and how long prior to the X-ray. And this is just a kind of visual abstract. Nowadays, everybody does one of these visual abstracts that goes on Twitter or social media to talk about how to a practical management plan for radiologists and how to manage these enlarged lymph nodes. And again, really relates to understanding the timing of the vaccine, the side of the vaccine, and whether we might anticipate seeing enlarged lymph nodes due to their medical condition, primarily cancer being the ones that we're thinking about. So how is now this delay in screening mammography and the delay in operating, the delays in radiation therapy and chemotherapy going to impact future survival from breast cancer? And we're starting to see some modeling from this. There was a publication in Lancet Oncology that says we're likely and potentially going to see an 8 to 9% increase in the number of breast cancer deaths up to 5 years after diagnosis due to delays in screening and delays in people coming in to get treated for a palpable abnormality. And Dr. Sharpless, who is the head of NCI, through some modeling that was done at the University of Wisconsin, has predicted a 10,000 person excess deaths in 10 years from both breast and colon cancer. I don't think we know definitively what's going to happen, because we certainly know that at times we have overdiagnosis of cancer, but we are very worried that some of these more symptomatic cancers, patients have stayed at home, and or those that really need to be screened aren't getting screened in a timely fashion. Some other data we have is there was a report out of Britain showing a 28% decrease in referrals to a breast center over the first 6 months of COVID, and a 16% decrease in the total number of patients undergoing a first treatment in comparison to what happened in 2019. There's also been kind of a 40% decline in the use of a breast cancer calculator, indicating that there's not as much activity in evaluating patients for breast cancer who are at high risk. Now, this is one of the busiest slides, but what I wanted to highlight is something I've mentioned before, that we had to take a very quick approach to changing how we treat breast cancer. And one of the things we did in pretty significant numbers, probably over 30% of the time, is take patients who had an estrogen positive tumor and place them on a really non-toxic medication, that being anti-estrogens or anti-hormone drugs like tamoxifen or anastrozole. And this is just an algorithmic approach to how we would approach patients like that to ensure that we didn't pick a wrong first approach to treating patients with an estrogen positive tumor. So another thing to kind of talk about and understand is, for our patients that do have breast cancer, what was the impact if they actually got a COVID-19 infection? And there's actually not a lot of data out there yet in the literature on this. There's a lot of anecdotal reports of how we've managed COVID-19 patients in clinic. There's certainly a lot of stress around ensuring that we protect the healthcare population as well as the other patients in clinic for those that might be COVID-19 positive, ensuring social distancing, masking, and appropriate isolation of those that are positive. But did it impact how the patients are getting cared for? And this is just a prospective registry that was developed at the Institut Curie in Paris, and showed that of the 15,600 patients they treated in their breast center, 59 developed COVID. Of those 59, 4 unfortunately went on and died, and primarily they were individuals with significant comorbidities, cardiac disease, diabetes, and existing pulmonary abnormalities. And so really not showing a significant risk from COVID-19 infection in a small population. This is only 15,000 patients, but just something to be aware of, that I think the medical community is able to treat and or manage the COVID-19 patient population, even though they may be undergoing simultaneous treatment for cancer. And this leads me to kind of that thought process around how do we manage patients, not that we all have ever dealt with a pandemic in the past, and where can we learn from structural organization that helps us inform how to manage the COVID-19 pandemic in different populations? We know we have seen significant disparities in populations getting COVID-19 as well as dying from it, especially those in, kind of that ethnically diverse population. So this was an interesting study kind of looking at taking a lead from the Cancer Prevention and Control Network and how they approach policy, engagement with a community, organization, and individual treatment options for patients with cancer, and melding that into kind of learning from the COVID-19 pandemic and making improvements in our cancer care approach and policy based on the kind of massive expansion of health population information during the COVID-19 pandemic. So that kind of concludes my slides. And what I wanted to talk through and help frame conversations around were each of these pieces of the puzzle, that being how did we rapidly change our approach to care for existing breast cancer patients? What happened in our mammographic screening populations, and what do we expect in the future going forward based on this V-shaped curve? Early in the pandemic, understanding we may have seen another V-shaped event happening as we got a resurgence in that November and December time in 2020. And then what can we expect going forward in terms of long-term outcomes from these delays in care? And how is COVID-19 going to actually impact an acute setting cancer treatment? And are we going to see any impact to the virus on those who were infected in subsequent cancer occurrence? So I look forward to your questions and appreciate you listening and watching those slides for that short period of time, but I appreciate and hope we can have kind of an interactive discussion and help answer some questions. Paula, I'll turn it over to you to help with some of those questions.
Hello, thank you so much, Dr. Wilkie, for your presentation. That was just really great. And it was just so good to hear some of the research, this early research that's coming out of all the work that's going on right now, especially with breast cancer. I'm going to go ahead and look at these Q&As and go ahead. Of this, what are the baselines of mammography among these groups?
So that's a fabulous question. And I was actually surprised that I saw that the Black and Caucasian population had similar resurgence. You have to take that with a little bit of a grain of salt of understanding that that's a patient population that's being captured and evaluated. And so what we don't know is and though I will say the BCSC looks and seeks for information on patient from underserved populations. And I think we can expect to see, as we did with the COVID-19 infection, that the ethnically diverse populations may be at a disadvantage in getting back in to get their screening. But certainly in this early data, we're not seeing it in a strongly negative fashion, except for that one study that looked at it from the Asian and Hispanic populations, where we are seeing a lack of return to standard levels. And again, those standard levels are in the 70% range. There's another study that was done through the American Cancer Society that isn't quite published yet, but looked at a program that they had to increase mammographic screening in ethnically diverse populations that was really showing great improvements between 2018 and 2019. And then the pandemic hit. So they had funding actually from the NFL, which I thought was interesting, to increase mammographic screening in disparate populations, showed a significant jump of about 20% in screening rates among those populations. And then during COVID, it didn't go all the way back down to pre-pandemic or pre-2018 levels. It went back down just a little bit. So I think the initiatives in those populations were working and worked during COVID as well. I hope that answered the question.
Thank you. Thank you. I have another question here. It's did the pause in people getting mammograms last spring cause people to be diagnosed with later stage breast cancer?
Well, for those of you who don't know, our cancer registries lag behind a little bit, and they are what we use primarily to look at stage by year. And our cancer registries haven't caught up yet with what happened a year ago. We're just now going to see it because that was a year ago. And so the lowered screening rates that happened in March, April, May that you saw in each of those slides, we are now going to see March, April, May, the staging data. So it's not out there yet, but we're all interested in it and starting to look at it. I mean, I can only tell you anecdotal what I see in my health system, and we certainly have seen many more palpable cancers than we have screen detected cancers in the last few months. But again, that's completely anecdotal, and we're just now going to see the impact of a year ago on staging, but it's certainly something we're all very interested in.
Mm-hmm. Okay, and this next question is about telemedicine. Did telemedicine play a role in your communication with patients over this last year?
What a great question. I think our medical oncology colleagues had a intense increase in the use of telehealth because patients didn't want to come in when they were immunosuppressed and not, didn't feel safe coming into a health system. And so the rapid increase in the use of telehealth happened primarily with medical oncology, a little bit with radiation oncology. For those of us in surgery, we did not see as much of a rapid increase in telehealth use. And the reason was that if a patient had a palpable abnormality, I'm going to confess, I kind of had to see them. I couldn't do anything over video. So we maybe started incorporating telehealth later on as patients, we could do their post-operative visits via telehealth. We could do follow-up discussions and questions via telehealth, but we really couldn't do management decisions and discuss surgery without physically seeing them. And so it was a rapid increase in use in our medical oncology colleagues' consultations. It's certainly been used frequently for second opinions, but if a physical exam was required, we really had to see them in person. And that's where we had to do rapid change in what we did in clinic in terms of enabling social distancing, separating people using masks and face shields to make sure that the providers weren't exposed and the patients weren't exposed to us because we were seeing multiple people. But telehealth was definitely something that expanded rapidly and could be used by select groups. And we saw a lot of positive feedback from patients. So patients really enjoyed the opportunity to be able to stay home for their post-op visit, not have to come in. They said their wound looked fine. If they thought it looked fine, I thought it looked fine. Really not have to come in for repeated follow-ups. And let me step back. I actually have another thought that just came to mind. A lot of our survivors, we were able to do telehealth with, where they didn't need to be coming into clinic. We could help answer questions remotely. But that was during a time when we weren't really doing mammographic evaluation. Now that they're coming in for their mammograms, we will see them at the same time they get their mammograms. So hopefully that helped answer that question.
Yeah, absolutely. And, I'm wondering too, when it comes to the pandemic, I mean, this was something, of course, nobody could have predicted. And I'm wondering over this last year, if you have thought about ways that if this ever happens again, or something like this ever happens again, how we could change the way that we have talked about screening, and making sure people do get their screenings. I don't know if there is a way to do it differently, but I wondered if that's crossed your mind at all.
Actually, there's a fabulous article that was just published about screening at home. And it's an interesting study about colorectal cancer now that we can do stool studies for colorectal cancer screening. So that's something you don't have to come into the hospital for. Whether there's any ability to do kind of this remote x-ray for lung cancer screening. But because a mammogram requires compression, there's no real way yet to do it remotely, though I think people are starting to think outside the box around that. But I think we've learned so much during this pandemic. I will say the one piece of the puzzle I forgot to mention early on in my talk is, for those of you who don't know, as New York got hit pretty quickly early in the pandemic, it was actually discovered that the mammographic technologists were had a high rate of getting COVID-19 because there was no social distancing when you do a mammogram. You know, if you've ever had a mammogram, you're standing right next to that technologist. And so there was a lot of transfer of COVID-19 in that process. It's why the American Society of Breast Imaging said, shut down mammography. It's why we went to zero, to learn new protocols for cleaning the machines, as well as that social distancing. How much did we need? Masks, face shields, PPE, to make sure that there wasn't transfer between the two individuals. But it was a lot of learned information from the mammographic technologists and what happened to them early on in the COVID pandemic.
Yeah, there's just so much that we've learned over this last year. It's amazing. So you're getting lots of questions here. I have another one for you here.
I know I can't see it and see you guys, so I apologize. I can't see it at the same time.
And I feel like I'm peppering you, but there's just so much people want to know that I can't help but just give them all to you. So the next one is, what types of outreach programs are happening now in underserved areas to promote screening and treatment?
So I think different communities do different approaches. And it's kind of funny. I was on a call earlier this morning with our Cancer Health Disparities Initiative. So we have a group that is focused on ensuring we try and reduce cancer health disparities. And we were talking about the importance of communication and what that communication looks like in different communities, whether it's Hispanic, African-American, Asian, mixed populations, and how we best message screening. So the group through the American Cancer Society that has this funding for, and I'm gonna say I'm not exactly certain what the grant is called, but I believe it's called the Change Grant, is using multiple different communication tools to different populations, whether it's meeting in community centers, church organizations, at sporting events, believe it or not, to try and educate people around the importance of screening, what the timeline should look like for screening. And some of the messaging is also around the fact that even though screening may be a little uncomfortable when you get a mammogram, that finding a cancer earlier means less treatment, less need to go to the doctor more often, less smaller surgery, less chemotherapy. There's, a lot of studies around the fact that screening does reduce and improve survival, but more importantly, it reduces what we call morbidity, which means having to do a lot to the patient to keep them alive. And so lots of initiatives around how to message that through different groups, different venues, and really convincing and using patient advocates. I think we've done a lot. The American Cancer Society has done a lot around using patient advocates to explain the need and the why for screening.
That's great. So following up to the questions about telemedicine that we had before, what changes do you think in breast cancer screening and treatment that have occurred during this whole COVID crisis we've been in will be maintained after the pandemic ends?
So I think if I had to kind of list some of the things that'll happen from a breast cancer standpoint, you will see an increase in the use of endocrine therapy, which means doing an anti-estrogen type medication prior to surgery to determine response and potentially treat patients for a moderate amount of time with those medications. That will help us continue to reduce the amount we do to patients for those that are responders, in that we can do less surgery, less evaluation of lymph nodes, and potentially reduce the amount and or if they receive radiation. The other thing that'll happen is that we'll increase the use of telehealth for our survivors, and really reduce the number of clinic visits patients need to have. We really need to risk stratify. You know, people do not need to come to the hospital and clinics all the time. We've got to reduce that. And now we can think more about the use of telehealth versus spacing out returns to the hospital and for evaluation if it's not going to be value added. And I think we've learned a lot about that during the pandemic. So in addition to this kind of neoadjuvant endocrine approach, increased telehealth for our survivors, as well as second opinions. We've learned a lot that we can remotely communicate with people. Look, I'm talking to people in New York and I'm standing not in New York, and figure out how to provide second opinions and really do that across multiple different kind of communities. Like if there's a small rural community and they have a new breast cancer patient and a young individual, we can really provide that telehealth approach and say, here are the things do in your community with her, and here are the things she should come see us, so that she's not doing that back and forth all the time. So I really feel like it's opened up the opportunities for engaging smaller health systems and larger health systems to work collaboratively, and the use of the telehealth for both the patient as well as providers.
Do you think, like anecdotally, from your perspective, have you heard from patients saying that I'm so glad we have this telehealth now, or I would want to keep it this way if I could, or the opposite? Have you?
It's actually been very mixed. Mm-hmm. It's been extremely mixed. We have some patients who have, and you hear this from providers around the country, that some patients love it. They love being able to incorporate it into their regular day and not have to get in the car and go park. You know what? No one loves to park in a health system. I guarantee you parking is not good at most large academic medical centers. And so the ability to not have to park has been fabulous for some patients. Other patients, they really need that physical engagement. They need that eye contact, because now that's what it is. They need to hear and talk to you in person. And so I actually think, like everything we do in cancer right now, in cancer care, it should be individualized. The patient should be given the opportunity to say, hey, can I do this via telehealth? And if we think we can, great, let's do it that way. But if the patient feels like I need to see you in person and it's a safe thing to do, then I think that's a great opportunity. You know, I think it should be individualized just like everything else we do.
Mm-hmm. Mm-hmm. Okay, another question for you is, can the COVID vaccine be a negative factor in women dealing with cancer treatment or in remission?
So great question. You know, early on, there was a lot of hesitancy about giving patients who were in active chemotherapeutic treatment the COVID vaccine. The same was true that when was the safe time to give it to them around the time of surgery. For those in remission, we really feel like it's safe. Every patient I see in clinic or talk to via telehealth, I say, if you get an opportunity, go get your vaccine. Just do it in the side that didn't have the cancer. Do it on the arm that didn't have the cancer. For those patients who are about to undergo surgery, though remember, we're learning as we're going. Our current thought process is don't get the vaccine 3 days before surgery and wait until 3 days after surgery to get it. The reason is you may be slightly immunosuppressed around the time of surgery and you may not respond as well. So that's our current recommendation, though again, it may change because we learn more about the vaccine and COVID and when it's safe. For patients getting active chemotherapy, there are a lot of different recommendations. And so I always tell patients to talk to your provider because it really may change on a weekly basis.
Mhm, mhm. That's really good information. All right, so here's another question for you. The pandemic has had a big impact on fundraising for cancer research.
Oh, yeah.
Are you concerned about the availability of funds that are, the amount of funds that are available for future projects?
What a fabulous question. So it's actually been interesting. There have been increases in giving from existing donors, and then a lack of kind of engaging new donors. And so we are worried that there's lower philanthropic funds to support everything from basic research to community support. But we're hoping as we start to emerge this next year that we'll get re-engagement. We're gonna have to prioritize, just like we did everything over the past year, is prioritize those projects. And I would immensely say that ensuring that our ethnically diverse communities get in and get the proper treatment that they need for either an existing cancer or screening should be a high priority. In addition to novel non-toxic therapies. So let's hope we can target monies that we do get. But yes, am I worried about it? Of course. But hopefully we can do and learn from what we've done over the past year is prioritize what we use it for.
Mm-hmm. And work like what you do, I think starts to get the word out again about, it seems like everybody, the whole world has been so immersed in COVID that, it's like something like breast cancer, especially with screenings, people may have thought, I can just do that later. Right now, I'm just staying home and I'm not leaving. And so now the work that you do is also just getting that word out again, the research that you do and everything about the importance of this. So
no, I think if there's some singular messages that I would give is that we learned a lot in the first 3 to 4 months of the pandemic in terms of safety in a hospital. It is now safe to come into a clinic and a hospital because we really figured out how to do this in a safe manner. Yes, we're all tired of COVID, but we have to recognize that we don't want the degree of infection and death that happened early on in this pandemic and in that mid-surge to happen again. So we want to encourage populations to get their screening, make sure they make the appointment. If you make the appointment, you're likely to go to it. And so going ahead and doing that now, whether it's for breast cancer screening, cervical cancer screening, colon cancer screening, because finding a cancer earlier is always easier to treat. And for anyone with symptoms, it is safe to come in the hospital. We certainly have seen our older populations being resistant to coming in the hospital up until about the last 2 months. And that's because they're now all vaccinated. Our older population is now all vaccinated. So it was actually kind of fun to have them, the older women are coming back into clinic if it's appropriate for them to, because their ability to do the telehealth has been kind of limited. I had a fabulous story of an older woman coming from an assisted living, coming in with a new cancer, palpable mass. And we were doing a discussion around how best to treat it. And she wanted to involve her daughter. So I took the phone number and I said, well, why don't we put your daughter on FaceTime? And she said, what? And so I pressed on her phone, the FaceTime, and that was the first time she'd seen her daughter in 7 months. So I don't know if her daughter didn't want her to know how to use FaceTime or not, to be honest. However, it's those kind of interactions of where we've learned to use telehealth, which populations is it good for, which populations is it not, and the safety of coming into the health system now is very high. Mm-hmm. We have the PPE, we know how to do the distancing, we know how to keep people safe, we know how to separate the actively COVID positive patients. And so I think people need to realize it's time to come get your screening, please.
Yes. And that's a great takeaway message too, that, just from what you said before about, those first 3 or 4 months, hospitals really learning how to make sure that everything is safe and that it is safe now to come. And somebody just put into the chat that about the cancer services program. That is
for
a
those
program.
of you, actually, that's a great thing, because for those of you who don't know, the CDC actually funds every state has a cancer, what you all call in New York State, a cancer services program for breast and cervical cancer screening, as well as colorectal cancer screening, getting it for those that are uninsured and underinsured. And it's a fabulous program nationwide to help people get their screenings and get them in a timely fashion. So I highly encourage people to kind of connect with those programs for their patient populations that need it.
Yeah, and I'm going to second what you said too. I know that here in Rochester and the surrounding counties, the CSP of the Finger Lakes does a fantastic job. I've had the pleasure of working with some of the people on that program, and it's just, they do such a great job. They really care for people all the way through the process. And yeah, I have to just second what you said for sure.
So Pamela, I just quickly looked at another one of the questions about the enlarged nodes and the COVID vaccine. That has been one of our challenges. Interestingly enough, early on when we were noticing this in December and January, I was on a teleconference with a vaccine expert, not Fauci. I would have loved to have been on the phone with him. But talking about how he kept saying, don't say anything, don't say anything, don't tell people this is happening. And we all said, we've got to tell them, they're going to figure it out. We've got to message this correctly because it's going to happen and it's going to make people more fearful. And so what I tell people is that it is always transient. We have proven that, but with follow-up ultrasounds, it is an important part of the inflammatory process, though we're not certain it means you're having a better response. Nobody's certain that that's actually a true statement. That as long as you tell a technician, whether you're getting a CAT scan or a mammogram, that you've had a COVID vaccine and on which side, then the radiologist can interpret it appropriately. If they have any concern, they can always do a follow-up ultrasound and prove that it got better. What we're telling people is a 6 to 8 week time frame that those lymph nodes should return to normal, sometimes as long as 3 months. Did I get that question right, Pamela? Because I kind of read it fast.
Yeah, that's good. Thank you. All right. Well, I think we actually were able to cover all these questions. Let me see. Oh, no, we have a few more here. This is just information. This is information from someone who is who works with the New York State Department of Health, providing insurance for, or providing assistance for individuals who would like to enroll in health insurance. So also just letting people know that there are health insurance options that are out there as well for people. So that's great. That's great news as well.
No, I think as over the last, I would say, I've been in this business 20 years, and I will say these resources didn't exist 20 years ago. And now we really have throughout, large metropolitan centers with extension into our more suburban and rural areas, patient advocates, health advocates, helping people figure out how to get insurance, helping people get appropriate screening, trying to break down those barriers that we've all seen in the past. Certainly, there is a ton of work to do to help overcome. I'll give a great example. I have a mammographic technician that I work with who's African-American, who's just unbelievable. But she's gotten her vaccine, and her siblings have gotten their vaccine, but her parents won't because of that fear about coming into a health system and getting something that they're not certain is safe. And so it's that generational difference. And so really trying to break down those barriers of generational distrust and improve through multiple communication pathways, whether it's patient advocates, community navigators. We need to do that across the spectrum to improve screening and thereby find cancers earlier.
Mhm. All right.
I thank
Well,
everyone. I was going to say, I thank everyone for their time. These have been fabulous questions. So I really appreciate the engagement. And hopefully this next year will get better.
yes, yes. I appreciate so much you coming and visiting with us, Dr. Wilkie, and sharing so much with all of us. And thank you to everybody who has been joining us on our Zoom community conversations. We will be having another one next month. We'll be talking about clinical research. And in the meantime, enjoy the day. I don't know how it is where you are, Dr. Wilkie, but where we are, it's actually sunny outside, which is very nice.
Okay, it's Friday afternoon. Everyone should go outside.
Exactly. All right. Thank you so much, everybody.
Thanks. Bye.
Bye-bye.